Good evening, everyone, and thank you for participating in the McCabe Centre for Law and Cancer and Cancer Council Victoria webinar on advanced care planning for health professionals. My name is Sonia Brockington. I am the Knowledge and Training Manager for the McCabe Centre for Law and Cancer, and I'm very happy to be your facilitator for the webinar this evening. Before we begin, I would like to acknowledge the traditional owners of the lands we are meeting on today. I would also like to pay our respects to their elders past and present and all Aboriginal people participating. Today's webinar will be about 1 hour. This will be followed by 30 minutes of question time in which participants can stay online to participate in the Q&A with our panellists. We ask that during the webinar you turn off your phone or alerts if you are listening on a device. We'll begin tonight with Dr. Deborah Lawson, who's a legal policy advisor for the McCabe Centre for Law and Cancer. Deborah will introduce the McCabe Centre and provide some background on the origins to this webinar. We will then hear from Sam Breen, who is Senior Nurse and Program Lead for Advanced Care Planning at Eastern Health. Sam will talk about how to start the conversation about advanced care planning with your patients. Clare McNamara, who is a legal officer at the Office of the Public Advocate, will then describe the key legal frameworks associated with advanced care planning and provide guidance on how the Office of the Public Advocate can assist health professionals with advanced care planning questions. After the webinar content, Sam and Claire will be joined by Deborah and Dr. Anna Ugaldi for a panel discussion. Anna is a Deakin University and Cancer Council Victoria Research Fellow with an interest in advanced care planning. The panellists will provide their perspectives and reflections on starting the conversation about advanced care planning and understanding the law. The panel will also respond to questions that were posed by members of our audience at the time of registration. We would like to remind you that we will be online from 6:30 till 7 p.m. to answer further specific questions about advanced care planning and also to provide more information about the services offered by Cancer Council Victoria and the Office of the Public Advocate. Please stay and chat with our panellists. You will notice there is a question and answer function within this webinar platform. Please note we have disabled this function at the moment, but will be available to you at the top right-hand corner of the webinar platform at the conclusion of the webinar. We hope that many of your questions will be answered during the webinar, but the Q&A period will provide the opportunity for any unanswered questions to be addressed, so we hope you will be able to join us. In relation to tonight's topic, we understand that we are discussing can raise sensitive issues that may be upsetting for some people. But we do need to remind participants that whilst the information can be quite personal, this is a public forum and we encourage people to consider this when commenting or asking questions. If you do find that the discussion is causing any distress, you may like to call Cancer Council's 13 11 20 number, which is the gateway to all information and support services provided by Cancer Council Victoria. This phone line is staffed from 9 till 5 Monday to Friday by practicing cancer nurses who are on hand to provide information and support whether you have cancer or are a family member, friend, colleague or health professional. The service is free and all calls are confidential. At this point, I will hand over to Deborah to introduce the McCabe Centre for Law and Cancer and Cancer Council Victoria's work in this area of advanced care planning. Deborah is a legal policy advisor with the McCabe Centre and is currently working on legal issues that impact on cancer treatment and supportive care. Her projects include the Making the Law Work Better for People Affected by Cancer project, supported by the Legal Services Board of Victoria. Deborah trained and practiced as a lawyer in New Zealand before undertaking a PhD in law, and she has a background in health law research and human rights. Over to you, Deb.
Thanks for opening that session, Sonia. I'm going to provide some brief background before we get into the presentations proper. The McCabe Centre for Law and Cancer is a joint initiative of Cancer Council Victoria and the Union for International Cancer Control. It's a specialist law and cancer centre based at Cancer Council Victoria, and its aim is to contribute to the effective use of law for cancer control. Our work spans domestic and international law with a key focus on the role of law in combating the rising global burden of cancer and other non-communicable diseases, particularly in relation to tobacco control and regulation of other cancer risk factors. We also have a strong interest in the intersection between law and cancer treatment and support. We were fortunate to secure a major grant from the Victorian Legal Services Board to support our work on legal issues that impact on experiences and outcomes for people affected by cancer. Our Making the Law Work Better for People Affected by Cancer project has explored legal areas as diverse as access to treatment and care, discrimination, regulation of alternative therapy providers, informed consent, and end-of-life decision-making. We place particular emphasis on improving the understanding and the use of law in these contexts, which is key in the end-of-life setting. Which brings me to why we're running this webinar tonight. In April, we ran a webinar for people affected by cancer and their carers on contemplating and communicating their future healthcare wishes, with an emphasis on what people need to know about the law. It turned out that roughly half of the participants in that webinar were actually health professionals. So tonight's webinar is responding to the interest that we know health professionals also have in this area. If you are interested in viewing the earlier webinar, you'll find a recording on the McCabe Centre website by clicking on the Events tab and also on CCV's YouTube channel. Understandably, health professionals may experience challenges in initiating conversations about advanced care planning. It can be difficult to talk to patients and their loved ones about things like losing capacity and planning for the end of life. Even if you're comfortable starting the conversation with patients, the legal framework governing decision-making at the end of life in Victoria is complex. Different state and territory laws can make it even more difficult for patients, carers, the community and health professionals to understand the law in this area and how it impacts on decision-making. The terminology alone can confuse. For example, the term advanced care directive can have different meanings in different states. In some states, it encompasses the appointment of a substitute decision maker, and in others, it refers only to a written record of wishes, usually in respect of refusing particular treatments. Therefore, it's unsurprising that there is evidence of significant knowledge gaps among health professionals about the law relating to end-of-life decision-making. We're hoping that some of these gaps can be filled tonight by our expert presenters. And finally, before I hand over to Sam, it's important to be aware that although we are giving information of a legal nature in this presentation, the discussion today is not legal advice and should not be relied on as such. If you do have specific questions about your personal circumstances, then it's important to seek independent legal advice. We can provide information and support to do so through the 13 11 20 line, or you can contact the Office of the Public Advocate, which Claire will discuss in more detail in the second half of the webinar. The legal information presented in this webinar is also Victoria-specific. As I've mentioned, the law relating to advanced care planning does vary from state to state, so if you are listening in another state, please bear this in mind and seek further information through the Cancer Council in your state or territory, which you can also do by calling 13 11 20. It now gives me great pleasure to introduce Samantha Breen. Sam is a senior nurse who is committed to the delivery of support and information to families regarding advanced care planning and the provision of quality education to health professionals at all levels. She is the program lead for advanced care planning at Eastern Health, which receives her current state funding to implement advanced care planning across 7 hospital sites, 4 residential care facilities and a community of over 1 million people. Over to you, Sam.
Thank you. Good evening, everybody, and thank you for the opportunity. So I'm actually going to focus on how to have the conversation in my presentation. But what I wanted to say today, before I start, is that the reason I'm talking to you is as health professionals, what we do every day is important. We have a huge impact on the people we care for, their families, our colleagues. And I think one of the most important things is to recognise that and just acknowledge that what we do is important and how much of a difference we do make in patients' lives. And it's certainly something that I reflect on in my practice continually, and I'm always learning. And as we go through these slides, you can certainly see that this is an ever-moving, dynamic area. So I thought I would just spend one slide just saying what advanced care planning is. It's patient-directed, so it's actually a completely voluntary thing. It may include the person nominating a substitute decision maker, or it may not. It may actually ideally be planning for when the patient can't communicate for themselves. What I'm increasingly doing, though, in my practice is actually using it more like a guiding document, particularly for the chronic disease patients. So as time goes on, they can revise, update, change as their treatment requirements alter. And certainly I think it actually does help to prompt discussion with clinicians, particularly as I'm finding that there's a lot of people want to be involved in their treatment and in their care and in that decision making. But certainly it is we need to provide more opportunities. The document describes what matters most to the person, and often in health we may have our own goals for the individual. For example, it could be related to getting their blood pressure to a certain level, how they respond to treatment, how much their urea creatinine is. But the patient's goal is actually to get married, to go back to work, to be able to walk to the letterbox. And I think we need to verify what it is that they want to achieve. And what we gain from an advanced care plan is basically will guide and inform the medical management plan. So I wanted just to set the scene. And the literature tells us that everyone waits for everyone else to initiate the discussion. So the patients often wait for their doctor, the clinicians often wait for the patient, and in the land of general practice, in the continuum of healthcare, and a lot of primary health is vital because a lot of patients are actually handed back to their GP quite early in their care treatment, and so often the general practitioners are actually waiting for a referral or a communication from the specialist before they initiate the discussion. What I just referred before is that what we know is that there is evidence to say that the community, we do want to be involved. There's a great paper from the Department of Health to guide health professionals on advanced care planning. It's current right now for acute public hospitals, 2014-2018, to have the conversation. You can go online and get that, and I would recommend that you do. It has every aspect for the law, it has case studies, it has how to implement, and there's also priority actions for health services. And as you can see, with the National Health and Safety Standards, Eastern Health is coming up for accreditation, its periodic review in about 6 weeks' time, so we are quite across what needs to be required. And I think as an organisation for advanced care planning, as health services, we need to be ready for these discussions, and we need to have systems in place to support the activation, the awareness, and the notification that the patient has a document. A lot of times I hear that people are reticent to bring up the discussion because they think it actually might upset the patient. The evidence is absolutely not that. But I think we need to be guided and we need to ask these questions. So I know this data is from 2011, but there are newer evidence to say that it does not distress. Patients want to know the truth about their illness. So why is advanced care planning important? I think the 3 points highlighted on this slide probably, from my perspective, nail it, if I can say that on a webinar. Health is complex. It's lots of 1,000 shades of grey, you could say, and medical treatment decisions, there's a lot of things to take into account. Certainly regarding, if we're talking to family members, there's a study that said about 50% of families don't know the other person's wishes, so they actually may substitute their own wishes, values, needs and beliefs, because they're doing their best guess. I think that's really quite stressful for families because they might live with did we do the right thing? And we don't want them to have that burden. We don't want people to be in doubt. We want them to be confident in what they believe the person would want. And I think the default for health professionals as a registered nurse is we do err on the side of more treatment. So from evidence, what we know is that we manage acute situations very well, but most of us, 85%, will die from a chronic illness and not a sudden event. So, with the ageing population, I do want to say advanced care planning is for anyone over the age of 18, and it's actually not an ageist. It's not about not receiving treatment. It's about receiving the right treatment for the right person at, what's going to be beneficial and best for them, in taking into account what their perspective is, as well as medically what's possible. And I think one of the things we've got to realise is that many patients are young with chronic illness, particularly. So I wanted to highlight with the chronic illness why it's challenging in this cohort to discuss when the uncertain future. And I looked at respiratory and cardiac background papers for this opportunity to talk tonight on the webinar. And I think as health professionals, with the chronic disease, if someone has a respiratory disease and they have, for example, a pneumonia presentation, our response is obviously often reactive to that episode of treatment, and we may not look at the bigger picture to look at actually this patient is actually declining in health, and they may well die in the next 12 months. But we haven't identified that, or we think that they might actually bounce back and live for 10 years. It's very challenging at times to work out the trajectory of chronic disease. There is evidence about clinicians and potentially death-denying attitude. I think there's some papers written on that, but that we might avoid discussing death and dying because we don't want to upset the patient. But what we also realise is that we actually haven't asked them, what are they worried about the future? We need to ask our patients what's on their mind. They've got this diagnosis. What are they thinking about? Because they actually may well have thought lots of things but have not had the opportunity to discuss it. I think advanced care planning, some people when I mention that, their eyes glaze over. But here are some approaches on how to start the conversation. So first and foremost, it is an absolute team approach. Because you start the conversation, you don't have to finish it. You really have to have the opportunity to let the patients know they can have a way to appoint an advocate. They can also have a way to say and direct their health care. And I think the average length of stay in acute hospitals is about 2.6 days. So in the reality, there's very limited opportunity. So we need to make sure we're planting the seed, and the patient will choose when and where they want to discuss. But they need to be encouraged and that we can support them in that. So one of the things that I'm trying to embed in practice is how about making it routine care. So I think what we want to do is remember that people call it different things, and if we just take the approach that we're talking to all of our patients about advanced care planning, have you heard of it? Some people call it, the examples on the slides there, a living will, statement of choices. We have a visual tool, a brochure that we give to patients, and they can contact us afterwards once they're discharged, or we can actually assist them on the ward setting, wherever they wish. Another option, particularly with medical power of attorney, we have as your contact person, is this correct? It's really important that we make sure we have the right contact person. I think in this day and age of blended families, second, third, fourth marriages, a family is really who the patient tells us is their family, and that can be quite diverse. And again, have you any powers of attorney? If so, are they for medical decisions? They're simple, straightforward questions that I think aren't threatening, and I think anyone can ask that. When we get down to the nitty-gritty, I suppose, what to talk about, quality of life is really important. I asked a patient, a respiratory patient, what's their quality of life, and she said it's smoking, and I'm sick of everyone asking me that and trying to stick patches on me when I go to hospital. I said, well, let's document that so everyone's clear. I said, but you do know you're not going to be allowed home oxygen because you'll blow up the street. She goes, yes, I know, but enough's enough. Just give me a break. I've had enough. So when it comes to talking to patients, I asked another person what's their quality of life. They said, I have none. But we need to ask these questions and give people the opportunity to answer. Many patients have beliefs about life and death from a philosophical perspective. Many patients have done funeral plans, and certainly, but it is hard if they're facing their own mortality. But it's something that people don't often realise, that some diseases are actually a terminal disease. For example, that patients with dementia will die from that disease ultimately. And one of the things that when we're talking in a generic way, it's often helpful to ask how they talk to their family, their GP, or others about their health and what matters to them. I wanted to, as I'm talking to health professionals, and obviously that is a very diverse group, these are some questions from Dr. Andrea B., who's a geriatrician that she educates her medical staff with, and I just thought I would show you there that these are actually really good examples. what was it like for you being in hospital? I always think is a great question. Get some interesting responses to that. But I think that reassurance, there's no wrong decision, there's no wrong answer. It's about what your perspective is. And clarifying hopes and fears, I think that's really important. And often I actually talk to people about their preferences for care and then say, well, that's really important. Now, why don't we document it? The way we can do it is in an advanced care plan. So another thing what I would say is where possible be disease treatment specific. For example, if a patient's on dialysis, they might want to talk to you about when to stop. We need to be quite broad about that and talk about that. And also resuscitation planning. That is a subset of advanced care planning. But remember, a patient may wish to discuss that or they may not choose to. It's up to them. It's their plan. It's up to them how much they want to talk about. Again, I think one of the things I'm going to highlight on here, what would be important if dying? The reason I think it's really an open question because everyone is different. And I think one of the things as being a nurse and I've cared for many patients is not everyone wants to be in a side room. Not everybody wants to have music. Or one lady said to me, do not play the whale music. Do not do that. One person said, I prefer to be alone. We need to ask, if we asked all of us, we'd all have 100 or different things that would matter to us. One of the things I think for advanced care directives that we have done and some other templates have this is a space for messages to family and friends if you're unable to communicate. And we found a lot of people have actually taken that very personally, and it's actually brought families together. I had one lady though who said, I just want to write down, don't marry him. And she said, they'll know what I'm talking about. And two, I love you, I trust you, don't worry, I'm fine, I know, I'm ready to die. I'm okay with this. So whatever it may be. And obviously care after death, a lot of people have specific wishes regarding donation. And finally, what I would say for advanced care planning, they need to be timely. We need to be open to these opportunities. If a patient says, what's the future going to look like for me? We need to give them the opportunity to explore that and talk. And I guess I know everyone's time poor, but it's really important that we actually say, look, let's chat about that, but maybe we need to set some time aside, and maybe I can involve someone else to assist us with that discussion. It needs to be everyone's responsibility. We need to actually document well and clearly I document in the patient's language, and the sharing of documents is vital, that they've told their family, the GP and relevant other health providers. And so thank you very much, and there's some resources there. Thank you.
All right, great. Thank you, Sam, for that and sharing your insights and experience in the area. So now I'd like to introduce Clare McNamara, who will provide an overview of the law relating to advanced care planning. Clare has worked at the Office of the Public Advocate for 10 years, initially in the role of an advocate guardian and currently as a legal officer. The Office of the Public Advocate works to protect and promote the interests, rights and dignity of people with a disability. Clare is a member of the Law Institute of Victoria's Elder Law Committee and Health Law Committee, and in 2013 was the recipient of a Law Institute of Victoria Legal Award. Over to you, Clare.
Thank you. Thank you for the opportunity to speak to this topic. The challenge for me is to keep this simple because, as Deborah already indicated, the law is quite complex. However, that's the bad news. The good news is this: if you keep focused on the idea that we're talking about people's human rights, that really will guide you. That is the fundamental anchor point. And the quote that's on the PowerPoint slide there comes from not even an Australian case, but it's a case that is very often quoted. And also, to be clear that in this entire presentation, I'm only referring to people over the age of 18. There are some laws that are specific to children. Every human being of adult years and sound mind has a right to determine what should be done with his own body. So that's really, that, as I say, is the anchor point. The whole issue of whether somebody is of sound mind and what the implications of that are, that's what we will try to work through in this presentation. Now, there's a number of Acts of Parliament. I'm just going to take you through some of these. If you find the details If you're not familiar with this, feel comforted by the fact that our office is very familiar with these issues, and we have a number of publications. They're available on our website, and the details of the website are at the end of the presentation. Hopefully for health professionals, you are familiar with the term person responsible. It's not a very catchy name, and we know that in hospitals still there seems to be a preference for using the word next of kin. But next of kin doesn't have a legal definition. The person responsible is the person who a registered doctor or dentist should seek consent from if the adult patient lacks the capacity to provide consent themselves. Now, further on that slide, with these very uncatchy titles of Section 42M and 42K, they're references in the Act. Not everybody necessarily has somebody who would be their person responsible. If you've never appointed someone as a medical agent, you're not married, you don't have children, you don't have cousins, then you won't have a person responsible. And so there's a process by which a form can be completed and submitted to our office. That's the 42K. If a person responsible does not provide consent to treatment and the doctor or the dentist thinks that's not a decision that's been made in the patient's best interests, then they can go through a process of challenging that. And I've detailed the 42M process there, but I've noted that those notices are very rare. I've worked at the office for 10 years and I've seen 2. So what people ordinarily do is go to VCAT and they seek the appointment of a guardian. And VCAT can appoint a guardian to make various decisions, but they can appoint a guardian to make decisions concerning medical and dental treatment and other health care. And a guardian is one of the people who could be a person responsible. So I know this all sounds very confusing, but the best way to train everyone is always to ask, who is your person responsible? And to work through the flow chart that our office has, and get people to work through the hierarchy where their finger stops at what seems to be a category for them. So I suggest everyone listening does that at some stage. They have a look at who's of the person responsible and they work out who is their person responsible. Because if you don't like who your person responsible is, that is a very good reason to appoint someone to be your medical agent under a power of attorney. Now, one of the particular complications at the moment, given the date of the 29th of July, is that there's a change of law in Victoria from the 1st of September in relation to powers of attorney. So I don't want to needlessly confuse people, but there already is a range of documentation people might have around powers of attorney. After the 1st of September, there'll be a greater range. So the provisions in the Guardianship Act about enduring powers of guardianship and in the Instruments Act about financial ones, they will now be dealt with in one document under the Powers of Attorney Act 2014. So somebody might appoint someone with financial and personal matters in the one document. What you see on the screen now is who is the list of the person responsible. So I can look at that list and tell you that my person responsible is number 1. I have appointed someone to be my medical agent. If I hadn't appointed someone to be my medical agent, I would work my way down to number 4, an enduring guardian, because I've also appointed someone to be my enduring guardian, the same person. And if I hadn't got that, I'd get down to number 6, my domestic partner, who is the person I've appointed as my agent and my guardian. So have a look at that. As I say, if you look at it and think, goodness me, my person responsible would be my 19-year-old niece, and I don't think she's got a clue to make the important decisions in my life, this is when you make a power of attorney. Now, the key piece of legislation really about refusing medical treatment is the Medical Treatment Act. So whilst under the Powers of Attorney Act you will be able to appoint someone to make various decisions, including health decisions, only a person who's been appointed as an agent under an enduring power of attorney medical treatment has the power to refuse treatment. Now, whilst I'm loath to raise this as an example, it is in fact the best example to use. People who are adherents to the faith of Jehovah's Witnesses and hold particular views about blood transfusions are a group who are most likely to consider doing refusal of treatment certificates in relation to blood transfusions and to be very focused on wanting to do common law advanced care directives. If somebody's going to refuse treatment, they must complete a refusal of treatment certificate. So whilst very often doctors offer us treatment and we don't necessarily accept it, refusing treatment is of a very particular nature. And in fact, refusal of treatment certificates, may I say, are quite rare. Again, in 10 years of working at the Office of the Public Advocate with a team of guardians, 30 plus people who are professionally employed as guardians, making decisions about medical treatment all the time, I personally have only been aware of less than half a dozen refusal of treatment certificates. So at one level, this law is a little bit complex. At another level, don't get distracted by it. If it arises as an issue, you contact our office and we will talk you through it. There's a difference in law between common law and statutory law, and the Medical Treatment Act clearly allows for a statutory advanced care directive. So if I've been diagnosed with a disease, let's say cancer, and I don't want a particular sort of treatment, let's say chemotherapy, I can complete a refusal of treatment certificate and no one can provide me with chemotherapy, not when I'm competent and not when I lose capacity. I can appoint someone as my agent who could refuse the treatment for me in the event I lose capacity. Not in the presentation I'll be speaking through, but in the presentation you'll be able to open up. I've provided a few examples of the choices that people make and the lawful basis of that, particularly around that example of chemotherapy for a person diagnosed with cancer. Okay, this next slide details what will now be possible under this new Powers of Attorney Act. So I won't speak through that. Some of this really is just a reference point if you want to go back and have a look at it. And there's just a little table there trying to simplify the fact that we've got these two streams of legislation. I mentioned before there's no such thing, well there is such a thing as next of kin, but it's not the appropriate language to use. If in my little example here, John and Mary, my parents, John and Mary, married to each other, they are each other's next of kin. But if they've appointed someone else to be their medical agent, then that's the person who gets to make the decisions. They haven't chosen to appoint each other as that decision maker. Now, as has already been mentioned, people do define all of these things very differently, and lawyers are rather pernickety about definitions because things should have definitions. And so look, these are the definitions I've given. I regard advanced care planning as a much broader process, and advanced care directives are a subset. And then within that subset, we break it down into the statutory advanced care directives, and the law on that in Victoria is absolutely clear. And then we have common law advanced care directives, and the law on that is not absolutely clear in the state of Victoria for the reason that there's no case law from the Victorian Supreme Court or from the High Court. So if somebody simply writes down, to use my example before about a person not wanting chemotherapy, I would say if you've got a current condition and you definitely don't want treatment and you're concerned that when you lose capacity somebody might try to compel you to have that treatment, as a lawyer I would recommend somebody does a refusal of treatment certificate. It makes it absolutely clear. But if the person hasn't done a refusal of treatment certificate, they didn't know they could, they chose not to, and they just write down on a piece of paper, I don't want chemotherapy, it's going to most often be unclear the circumstances and whether or not they've been sufficiently informed. Now this is to reiterate a point that's already been made. Advanced care planning really is about discussion. Lawyers, of course, like to get to a point of being able to write things down, but you can't write something down unless you've had a discussion to start with. So documentation is great, but discussion is imperative. If you've had a really good discussion, you can write down something that will be a good reflection of your intentions. The other thing to understand about wishes is that they keep changing. When you're first diagnosed with cancer, your thoughts are going to be quite different to a month later when you know something, or 6 months later when you've had some sort of treatment. So a family member who says, oh, mum used to say something or other, doesn't make it concrete and binding. It's part of a narrative and you want to gather it all. I would say we don't want to just introduce the issue of advanced care planning with people because they've suddenly been diagnosed. I would suggest that's a really unfortunate time, in the same way as when somebody moves into residential aged care, to say to someone, do you want to be resuscitated? Have you made a funeral plan? Who's your power of attorney? And do you want to be resuscitated? That's not really the time to be asking. It should be normative to discuss this, not because you're old, not because you're sick, but because it's a good idea to talk about your wants and your needs. Now, whether somebody has decision-making capacity or not, their wishes are always important. It doesn't matter how demented an elderly person is. If they are capable of expressing their wishes, we must find out what their wishes happen to be. The person who might have authority as a person responsible to make a decision for that person who now lacks capacity themselves, their job is to make a decision in that person's best interests, and part of making a decision in somebody's best interest is to give effect to their wishes as far as possible. Now, at one level, this doesn't seem to be a very important point. What is medical treatment? But there are some things that doctors don't need to trouble themselves to get consent for. The administration of a pharmaceutical drug being the most important thing there. Unfortunately, in Victoria, we could have better harmonisation of our laws, because when we go to the Medical Treatment Act, we see there's a slightly different definition. So whilst under the Guardianship Act, the administration of a pharmaceutical drug doesn't require consent, under the Medical Treatment Act, the administration of a drug is medical treatment. These are the types of matters we have been agitating for law reform for some time. It's unlikely at a practical level to be of relevance, really. I would think the main example in which it would be is if somebody's wanting to refuse, for an elderly person in an aged care facility, wanting to refuse psychotropic medication. Now, palliative care, a person who the person responsible, a guardian, a medical agent, no one can refuse palliative care for a patient. So in a hospital setting, and I've had this situation, I was guardian for a gentleman once where his son was insisting that the hospital not provide palliative care to his father, because in his view his father was not dying, did not need palliative care. In a hospital's view, his father was suffering. In that instance, the son has, even if he had been guardian, even if he'd been medical agent, he would not be able to veto that judgment that the person's pain needs to be managed. If an agent or a guardian who's got the authority that's been given to them by VCAT is going to refuse treatment, there are two grounds on which you can do it. Because you think the medical treatment would cause unreasonable distress to the patient, or there are reasonable grounds for believing that the patient, if competent, and after giving serious consideration to their well-being, would consider that the medical treatment is unwarranted. This is the critical part for advanced care planning. I had a conversation with my own mother about these things, and she gave me one little nugget that I think is really helpful for me. She said, I'm not so convinced of an afterlife to be in a rush to leave this life. Sometimes it's those things that give you great insight into people, rather than giving you long lists of, I do want this treatment or I don't want that treatment. Now, most people don't understand the difference between withholding consent and refusing treatment, and if you're in that camp, that makes complete sense. This is a very legal, technical point, and I've only included it for those of you who want to go back and have a look at it, and you can work through that table yourself if you wish to do so. Okay, so I think the best way to do advanced care planning using the law that is available is to choose, if there is somebody that you can, to be your medical agent. And I understand that for some individuals there's not going to be someone who they can ask to fulfil that role, but if you do have someone to fulfil that role, do that. Don't just appoint them, talk to them. If you can, write down what you want, whether you've appointed a medical agent or not, and make sure you put that information somewhere that the relevant person is going to be able to access at the relevant point in time, which isn't going to be when the ambulance is called at 2 in the night and you've got it in a manila folder in a locked filing cabinet. I mentioned before the status of law in relation to common law advanced care directives is unclear in Victoria, so certainly people would not discourage people from documenting it, but there's no guarantees that it will be doctors will comply with it. The last couple of points I'll just make here is that advanced care planning is something, but it's not all things. And there's a difference between advanced care planning and substitute decision making. And put most simply, I would say that the only person who can do advanced care planning is the patient themselves. If they've lost capacity, somebody else can try to get a sense of what their wishes are, but it's something you need to do when you've got capacity. And it's different from clinical decision making, and this point's been made, but I'll reiterate it because I think it's really important. Families generally only get to make or seem to make a decision that's going to lead to the death of a loved one. Maybe not at all for many of us, but for those who do once, maybe twice in their life. So people are not expert in this, and it's overwhelming, and they have a lot of grief. So they should not be asked to make decisions that legally it's not theirs to make. So this relates most particularly to resuscitation. When somebody moves into aged care, their daughter shouldn't be asked, is your mother for resuscitation? It's not a decision really for her to make. Ordinarily, clinically, in that sort of situation, it would be deemed futile treatment, and there should be clear communication between the doctor and the family about that. In determining whether to offer treatment, the focus is meant to be on whether the treatment is worthwhile, not to get distracted by, gee, this person's 95, you think they've lived long enough or they've suffered long enough. They're the considerations for the patient or for their substitute decision maker. And there's a quote there from the BWV decision, which is the one where the Supreme Court determined that the provision of artificial nutrition and hydration is medical treatment and therefore it can be refused. Now finally, don't forget that it's the patient whose human rights we're interested in here. Family are important, but they are not the ones who drive treatment. They are a source of information, but it's the autonomy of the patient which is the critical point. Communication is vital, and I've got a little, sorry, it wasn't, I think, there is a checklist there. So when you look on the PowerPoint presentation, I think there's got flying in things I didn't mean to do, but if you look at it in your own time, it sets out a number of things that you need to work through, and as you do that with the patient and you hit a roadblock, that's when you contact our office. We've got lots of resources, and we take a third of our telephone calls relate to medical consent issues. So we encourage people to contact us, and we will talk you through these issues. Thank you.
All right, great. Thank you, Claire. So that brings us to the end of the webinar content, and at this point we'll move into our panel discussion. So I'll facilitate this part of the webinar, and our panellists will include Deborah, Sam, Claire and Anna Ugaldi. Our panellists will respond to some of the questions posed by the webinar participants at the time of registration. And as I mentioned before, there will be an opportunity to ask further questions in the Q&A session later on. So we'll move into our first question. So the first question here, as you can see, what needs to happen to better integrate advanced care planning into standard practice? And I'll ask Sam to start in response to this.
It's a great question, and I think one of the things is I've answered already, that I think we need to make sure that we ask those questions about person response, so we identify clearly who is a potential substitute decision maker. And I think one of the things that we've got to empower the broad multidisciplinary team. You know, when you look at how often case conferences occur, they often occur daily in wards. And advanced care planning isn't just for specifically trained staff. It is actually, all these conversations happen daily in hospital settings. We just have to make sure that we have the systems in place to make sure if the patient represents that we can continue the discussion and that other clinicians can identify it. So my thoughts are, it should be on admission. We should offer the opportunities when the person's well enough. I do agree with what Claire said. Ideally, the earlier and the normal things. I mean, I'd love to see this in schools. You know, I'd love to see this really early. At uni, at different things, that we're not afraid to answer this question. I think one of the challenges sometimes people as health professionals may feel, oh, I don't think I can do that. Well, in fact, you do it because you speak to your patients every day and you have that trust and rapport. And I think having a team meeting and identifying, has anyone asked these questions, maybe let's have a look who should, and then we can coach each other and then support and just learn from the patients or clients or residents and be guided by them.
Great. And thank you, Sam. Anna, did you have anything that you wanted to add to that?
In responding to that question, I think it's really important to acknowledge the barriers to ideal and optimal integration of advanced care planning. And there are lots of different barriers that we're aware of, both in the literature and through SAM's clinical practice. And they can be clinician barriers, such as a desire to maintain hope, but also a lack of time and time constraints. They can be system barriers, so things such as a lack of consensus around who should initiate the discussion, but also systems to record advanced care planning and to follow up and to make changes. And also there can be factors related to the patient as well. So we know some patients don't think that advanced care planning is relevant to them at particular points in their disease and treatment trajectory, but also there may be relationship issues or other things at play that can make them a bit hesitant to really engage in advanced care planning. So I think in the literature there are no kind of optimal models around how advanced care planning can best be kind of delivered and the best way to integrate advanced care planning. And I think that's actually an okay thing, because all of our sites are different, all of our services are different, and we all have different resources. So we certainly don't want to be overly prescriptive around that. But I think the message that came through in both of our speakers today is that we really need agreement that advanced care planning is part of everyone's responsibility, and I think that's a very important first step.
All right, thank you. So we'll move on to our second question, and I think, Claire, this one will be for you, and I think you did allude to this a little bit in your presentation already, but just in regards to advanced care directives and them being legally binding, could you just provide your perspective on this?
Well, the status of the law in Victoria is unclear, as I said before, because there's no determined case law, although we expect if it went to the court they would say the comment that they are binding. So at one level I realise this is quite frustrating for health professionals not to have clarity, but I think in a sense it's a bit of a red herring and distraction, because if we can encourage, even if common law advanced care directives were binding, there will always be some provisos around it. They'll need to be written in a clear and unambiguous way that the person intended certain things. So in a sense, if somebody's going through a good process and they're documenting it, that really is the gold standard of information to inform a substitute decision maker. So I'm less troubled by the fact that the legal status is unclear, because I think all the other issues are much more important.
I would absolutely concur from a sense of clinical practice. It's a question that comes up quite often. I do a lot of community talks and a lot to health professionals. It is common law, and I'm actually I think it should stay. I think it should stay as is, because if it makes it overly complicated, people will withdraw from the process. And what I would say is that for a document for currency and validity, recommend standard practices every couple of years they're reviewed, and we really want to make them really about so they can be followed. So rather outcome focused rather than treatments wanted, is one way of it's been approached with My Values and Charlie Cork. Is great work, and I certainly think that they are applicable and they're informative and they're evidentiary. So it's a starting point for conversation. And I think that's the ever-moving phenomena with them. But I think there has been other case law in other states, hasn't there?
There is, yes, the law is more settled in other jurisdictions. Yeah.
Okay. All right, thank you. So we'll move on to that next question, question 3. So, Sam, you mentioned an individual's values as being something that we need to think about, but also we are always striving to be more culturally sensitive and aware. So in a practical sense, how do you think cultural factors need to be taken into consideration during advanced care planning?
My perspective on this, culture is a very broad thing. It's much more than ethnicity, religion. I mean, within the English culture, as I'm English, there's a great diversity even within the next town. We sound different, we have different accents, we speak differently, we eat different types of food, and we're both all Caucasian in those examples I'm thinking of. But what I would say, it's about kindness and it's about being respectful. And I think whether or not you're talking to someone, it's really the simple thing is that we classify, is there anything culturally I should be aware of? Is there anything that you identify with? And is there anything I can consider? This is really important. I want to be respectful. And people can see kindness in lots of ways, and then we'll be guided by them, because not everybody, even if they identify, adhere to that particular faith or that particular specificity. So I reassure my colleagues that, just clarify, just ask. But kindness, your eyes say a lot if people are non-English speaking. And there's the consideration that you've actually thought to ask or that you want to make sure, have they got the people they want here? That's my perspective, and obviously there's a lot of more depth in there. But I just think don't be frightened with someone's cultural diversity. It's advanced care planning for everybody.
Yeah. Anna, did you have something that you wanted to add there?
I think the only thing to really add is that the literature shows, and through research studies, but also a recent literature review that came out of Queensland, is that there is some studies that demonstrate that minority groups are now less likely to have advanced care plans in practice. And I think this is very concerning, and it's certainly an area that we need to be aware of, both in any development of any research studies, but also clinically.
Great. All right. We'll move on to our next question, question 4. There seems to be some concern that the culture of oncology has been treat to the end. So do you think that that's mostly due to a medical culture that views dying and death as a failure, or do liability concerns also play a role? Deborah, do you have your perspective on this?
Sure. I think first we need to be clear about what is meant in that question by treat to the end, because if we're talking about palliative care and in particular treating pain and other really distressing symptoms, then I think many of us would want and expect that kind of treatment to be provided until the end. Obviously, I can't speak from an insider's perspective about the culture of oncology and whether death is viewed as a failure, but we're always really interested to receive questions like this and to hear health professionals, patients, carers and community views and experiences in relation to that. I would imagine that viewing death as a failure and having concerns about liability are not reactions restricted to oncology. But I think that advanced care planning, if it's done properly, is one really key tool in making health professionals feel more comfortable in making some of the decisions that impact on the extent of treatment that they provide at the end of life. Because if you can feel confident that you're acting in accordance with the patient's views and their expressed wishes, then that might go some way towards reconciling concerns about withdrawing or withholding treatment. And in terms of liability concerns, there is some evidence that some health professionals practice defensive medicine, so ordering all the tests they can think of and undertaking all possible interventions to reduce the risk of liability for treatment omissions. And you could see how this could be a particular concern in the end-of-life setting where the consequences of making a mistake are obviously irreversible. That said, the best way to avoid exposing oneself to liability is to understand and to act within the law. It also helps if the law is clear. And we hope that these webinars and other of the education sessions that we're doing and that the Office of the Public Advocate also does provide some of the legal information that's key to practicing in this area. And we're also providing important information about where to seek further support through forums like this if people are concerned about liability.
Claire, did you have anything that you wanted to add there from a legal and liability perspective, Pat?
Well, our office perhaps doesn't hear the story so much from the perspective of the culture of oncology, but certainly we deal with many telephone calls in relation to older people, and the idea of perhaps treating beyond the point that, particularly with resuscitation, when there seems perhaps medical practitioners feel that there's some pressure or expectation from family members, that is a concern because, again, to reiterate the point I've already made, they should be focused on their patient, and family might well have useful information, but their duty of care is to the patient. And if they form a view that it would be dangerous to the patient to be providing that sort of treatment, such as resuscitation, they really need to communicate to family members so they understand that. Because family might be coming from the point of view of, shouldn't we be doing everything that's possible? And they're not sufficiently well informed.
Sam, you had a little bit to add to this.
I think it's a great question. It raises lots of issues, and I think one of the things I want to just put out there is that recognising dying is actually quite challenging, and certainly in the oncology setting, from my understanding, is that patients will respond differently to treatment, and there'll be how the majority respond, and then there'll be the extremes. So some patients might die very suddenly, almost within a short time of diagnosis, and other patients may live longer than anticipated. So I think determining when we are nearing death is a challenge, but I think we have to have these open forums and these open discussions so we can learn. And I certainly think one of the things I would encourage you, if you're caring for a patient and you actually think, is this treatment appropriate or is this diagnostic investigation required, raise it, discuss it, and you can actually have a voice. I think we have to speak up if we are concerned in a clinical setting.
Thank you. And on to our final question for the panel discussion, which is to look at what actual language is important to use in these documents. So, Claire, what would your advice be in relation to this?
Well, I mentioned earlier that you'll get a good document if you've had a good discussion. So that's really where if you've had the good discussion, then you can commit it to paper. That's really what's going to be the most valuable thing. But I suppose there are some skills in writing, and one is to always consider who your audience is. So when you're writing it, who are you writing it for? Are you writing it to inform your substitute decision maker? Are you writing it to inform family members who might hold different views to what you want so that they understand that? Are you writing it for health professionals? Are you writing it for all those audiences? So just bringing the usual skills of good writing, clear, unambiguous, and considering whether or not you want to detail values, such as what matters to me is that I can still get out of bed, or I don't want to have dialysis. So whether it's treatment-based or values-based, and not to use really vague, some of the types of words I've seen people scrawl on documents such as, spare me the heroics. What does it mean? Or one lovely person who'd written on their medical power of attorney, spend the money on the younger generation. These types that we sort of get a little bit of an insight into where the person's coming from, but it's not in the end very helpful. So getting someone else to read what you've written and giving you some feedback would probably fine-tune it.
Yeah, and Anna, this connects with some of the research that you've been doing, hasn't it, around documentation. So what would you suggest?
Look, I think that in regards to the language used for the broader discussion, I think it's really important to note that when we engage with our patients in any way, we need to use language that they can understand. And this is true when we're approaching people for a research project or having discussions around advanced care planning. But I think it's really important to acknowledge that, as Claire has pointed out and has said today, is that some of the language around advanced care planning is quite confusing. It is a kind of a challenging thing to get your head around, and research suggests that it's challenging even for clinicians, let alone for our patients. So I think that's really important to acknowledge. We are doing some work in this area. We're doing a qualitative study looking at patients' comprehension of their current advanced care plans, and we'll have the results of that early next year, which I think will be quite helpful in discussions around how we can best have these conversations.
Great, thank you. So this brings us to the end of the webinar content and our panel discussion. And if you are interested, you can listen to our previous webinars conducted for patients and carers, as Deborah mentioned earlier. And the link is available to you from this webinar and also on the Cancer Council Victoria website and McCabe Centre website. I would like to thank our panellists, Deborah, Claire, Sam and Anna, and also to our support team here at the Cancer Council from the McCabe Centre and also the Cancer Information and Support Services teams. Just a reminder that we will now be closing off the audio, and at this point we'll be enabling the question and answer function and will be available online to answer your questions until 7 p.m. If you would like to ask a question to any or all of the presenters, please click on the icon in the top right-hand corner of your screen. Questions can be answered publicly or privately. If your question has sensitive information, we will answer it privately. And if it is a general question that could be beneficial for all, we will answer it publicly. Please indicate in your question if you would like it to be answered privately. And all of your questions will be viewed by all panellists. We hope that you have enjoyed the webinar and thank you for your participation. We do ask that once you leave the webinar, you do take the time to complete the exit survey, which will take about 5 minutes to complete and help us as we move forward into providing more webinars for professionals and the public. So thank you for your participation, and we'll go through to the question and answer at this point in time.